I'm Stephanie Shelton, and this is episode 37 of Conversations on Health, How We Get There. As I record this at the end of the second week in October 2025, the U.S. government is officially shut down. Senate and House Democrats are demanding negotiations with Republicans and President Trump to restore major health care cuts to Medicaid and the Affordable Care Act marketplace subsidies for 2026. It's expected that if these cuts aren't restored, and restored quickly, insurance premiums will double or even triple, and millions of Americans who now have at least some basic health insurance will be unable to afford any. Many small rural hospitals may have to close as well. Which brings me to the overall state of the U.S. healthcare system, such as it is. And my guest, Dr. Erica Rowe Urquhart. She's a leading orthopedic surgeon who runs a private practice in New Jersey with her husband, who's also a highly credentialed orthopedist. Dr. Urquhart has a PhD in molecular and cellular neuroscience and served her orthopedic surgery residence at New York's renowned Hospital for Special Services. After 15 years in private practice, Dr. Urquhart also got an MBA from Oxford's Said Business School, so she could deal with the ever more complicated insurance issues we'll be talking about, issues which often prevent even patients with good insurance from getting the medical procedures they need. She has a book coming out as well. We cover a huge amount of ground in our conversation. I think you'll identify with many of the issues we raise, and as usual on this informal podcast, we use first names. Erica, thank you so much for coming on the podcast.
Thank you, Stephanie, for having me. I'm excited to be here.
So I kind of want to start with what we're dealing with today, which for me, as on the patient side of it, is just a lot of uncertainty. But in general, if you look at the state of healthcare in the United States, what are you thinking about it? What are your thoughts, not so much for the future, but for the now? Who gets it? Who doesn't? Who benefits and who doesn't benefit? And we have great medical breakthroughs. Who gets them?
Yes, that's a phenomenal question. And it's a very complicated question, right? There are multiple layers to that question. But as you say, in order to really begin to look at solutions, we have to very accurately, if we can, describe where we are right now.
Yeah,
And I would say it starts with a very simple premise. It starts with the premise of the doctor-patient relationship. And culturally, I think that's something that most of us would agree is really important in our society in terms of the way that we approach healthcare. We approach healthcare from a perspective that doctors and patients should have a dynamic where there's mutual respect, there's understanding, and there is, if needed, education, where doctors as professionals who have trained many years in a certain area and have expertise can impart the information that they know to their patient and allow the patient to make an informed decision about how then they would proceed in having a healthful life. And unfortunately, because we operate in a society that requires a financial instrument, requires funding for the things that we do, no matter what we do, there's this third party that engages in this doctor-patient relationship. And sometimes they're seen and sometimes they're unseen. The third party is the mechanism of payment, right? The corporate insurer for most of us, or the federal government for those of us who can't afford it. And so what we're seeing currently in the state of healthcare is the increasing influence of this third party on the doctor-patient relationship and on the patient's ability to make healthful decisions for themselves.
Well, as we sit here and this is early October that we're recording this. Um, we really don't know whether a very large group of Americans are going to lose health insurance, therefore their health benefits, therefore their ability to go to the doctor for anything for many of them because they won't be able to afford insurance on their own. I think I believe that the statistics were with Obamacare and the growth of it, there were only about 9% now of Americans who are uninsured. And if we have cutbacks as are possible, we'll go back up to something like 18 to 20%. Does that make sense to
That
you?
makes sense. I've heard numbers as high as 24%. So
Mm,
potentially, one fifth to one quarter of Americans would no longer have health insurance or health coverage. And I think it's very important for us to understand that the current scenario, as you say, with that 9%, but let's, even group in those who may have insurance but are really underinsured. They
yes.
don't have the coverage that would allow them to do some of the things that, we just would expect that most of us would do, screening
Right.
tests,
Right.
and other things. We look at the current scenario, there is a deficit in terms of Americans' ability to take care of their health. Even those that are insured are presented with a scenario where they may choose not to engage in a treatment plan that has been devised in consultation with their physician because of the costs associated, be it time off of work, be it the out of pocket expenses that are associated with their health plan. So I've seen numbers between 60 and 75%, and these are surveys, of Americans are choosing not to continue with a health plan that's devised with their physician, with their doctor, because of the costs associated with that.
That's
So
disappointing.
we're looking at, adding insult to injury
Mm.
when we're looking at pulling away the benefits that currently exist for those that do require, these ACA benefits.
And the stupidest thing to me is I'm just looking at dollars and cents, which we all have to do to manage our lives. So if you have a small thing wrong with you and you decide I can't afford to go to the doctor because I might have to buy a drug or I might have to come back for more visits or get some sort of treatment. So I'll just let it go and watchful waiting and, all that. And then one day that person presents at the emergency room and there are all kinds of things and he's, dying basically. And that person costs the health system in general, who now is us, because we are paying for that person by our taxes, by our own insurance payments, all the rest of it. Costs, three, four times as much as it would have cost just to let him go to the doctor in the first place and get things straightened out when they were still able to be straightened out. Why don't these people understand that who make these decisions?
That's a phenomenal question. And again, I think it goes back to what we spoke about when you asked me the first question, because it really comes back to the corporate insurance dynamic.
Mm,
And what we are finding is that many of the major insurance companies, the largest is like a number eight Fortune 100 company.
yeah, yeah.
They are concerned, as are most corporations, with returning value to their shareholders. So they create barriers to care. And those barriers might be increasing copayments. So that means that every time one goes to the doctor, the copayment for me, for most of the physicians that I see, my copayment is anywhere from $45 to $150. If it's an emergency visit, it could be $150. Um, and that's out of pocket before the insurance even begins to pay.
Mm,
Many patients have plans where they have high deductibles, and that could even be for in-network providers. So by returning value to shareholders and creating these utilization management strategies, they are essentially penalizing patients for having healthcare insurance or for having policies and creating, again, these barriers to receiving care. Because at the end of the day, the objective, if we're looking at it from a shareholder perspective for these corporations, is to collect premiums, to retain those premiums, and to minimize the outlay of cash in the form of healthcare services.
I remember I am a journalist and I've been an on-air journalist most of my life, so I'm a member of SAG-AFTRA, and I had an experience where the doctor wanted to have my genes. I forget the technical name for it, but gene pattern or whatever it might
Mm-hmm.
be. Um, and the insurance company said no. And the end result was I did not have as good an outcome. Um, and I did not have as easy a time with the situation as I might have had they spent that extra money and done it. Uh,
Yes.
it was a while back now, maybe 10 years ago, but
Mhm.
it just seemed at the time, maybe it was because the whole gene tracing theory of dealing with things was still pretty new, but I was amazed. I didn't realize until then, as a patient, that an insurance company could just say, no, you can't have it.
Yes. And the language, as a provider, a physician whose practice attempts to get these authorizations day in and day out. And when it's denied, then we can request an appeal, and we can then request another appeal and appeal to a specialist in our specialty of healthcare to review the case. And the language that we're instructed, because, at the end of the day, if it's a denial, we could be frustrated. We'll say, oh, so you're denying. We'll try to rephrase, mirror back. Oh, so you're denying this service. And they'll say, oh, no, we're not denying. It's just that we're not going to pay. So I think it's really important, as you mentioned, for patients to grasp this concept that the insurers are not viewing themselves as entities that are bound by the Hippocratic Oath, right, to help patients to do no harm. They're viewing themselves as entities that are financial instruments. And it's very convenient to say, on the one hand, especially when the patient is signing up for the policy, we're for you, we're, providing your coverage for healthcare services. But then on the other end, to say, oh no, we're not denying the care. You can certainly provide the care, but as the financial instrument, we're saying the decision, the corporate line, the policy is we're not going to pay.
That's just amazing. And it makes, to all of us who just go in as patients. I mean, your frustration level as a physician must be up here every day.
Yes, it's a contributor certainly to burnout and to frustration with our profession. But then we're also being placed in the position by, again, these corporate insurance companies of being the ones to deliver the bad news, whatever that may be. The bad news that your copay for this visit is $45. The bad news that our office has attempted to get authorization for these services, but it has been denied. Usually we're the first to deliver that bad news. The bad news that we've submitted the claim to your insurer, and although we had the prior authorization, believe it or not, prior authorization is no guarantee of payment, and your insurer has decided to deny the claim on the back end because of whatever it may be. And you are now responsible for the cost of care. So we're being placed in this position to be the bearers of this terrible news that really is not of our creation. It's not our decision. We have no power. And it's the micro trauma, doing that over and over again, so many times a week, having to, try to encourage our staff to continue to push, to continue to pursue. Don't give up. Don't be complacent. It's quite a burden.
And you can't exactly blow up at the person on the other side of the line because they'll probably hang up on you.
There's no futility in that. Who wants to be on high blood pressure medications because we're constantly erupting, right? Uh, that's no way to live either. I mean, most of us believe in common courtesy, respect. We want to carry ourselves with a level of dignity. And it would be eroded if we were constantly blowing up at the person on the other line because they're not operating with the same moral compass that we're operating with.
Yeah.
So, actually, we're probably tamping down, tamping down, stuffing, trying to maintain the decorum and the dignity that is in alignment with our profession.
Yeah, well, that's not always good either, so
Right?
or suppressing emotion. Um, so I think I don't know, and maybe people now who deal with things a lot begin to realize this, but I didn't realize that literally everything you need to have done requires now prior authorization. I thought that was for specialized treatments and something beyond the norm. And I also didn't know that Medicare requires it now. So I learned that from doing my research on you, actually. Um, so really, no matter what you need, no matter how much of an emergency it is, I mean, can an emergency room go in and do some kind of emergency procedure before they go and say, well, does this person is a insurance going to pay for it?
That's a phenomenal question. So, just to backtrack a bit to your summary of the current scenario, the current ethos, our practice has been in existence since before I actually went into practice. My husband started our practice 25 years ago, and I've been with him now for 20 years. And over the years, we've seen, as you mentioned, the expansion of requirements for prior authorization even into Medicare, which did not have prior authorization requirements as recently as, say, 10 years ago for most procedures. And so that is something that even RFK Jr. and Dr. Oz held a press conference saying they had spoken with insurers and that they're going to, by the end of 2025, reduce the red tape, reduce the requirements for prior authorization. Well, on the other hand, as you mentioned, Medicare has prior authorization requirements. And for the upcoming year, Medicare has announced that they will be expanding the prior authorization requirements to apply to more services. So, on the one hand, they're reducing prior authorization. On the other hand, Health and Human Services, under which Medicare is a part, will be expanding the prior authorization services. And then, as you mentioned, going to the emergency room or emergency care. So, again, the way we do things in the United States is healthcare is provided. If a patient needs care, independent of their ability to pay, and I guess every state is different, but
Yeah.
in our state, in New Jersey, independent of their ability to pay, patients are to receive care.
Mm.
So a facility, a hospital is not supposed to look at a patient's ability to pay before providing healthcare services and emergent services. That being said, the scenario that we are in is that, say, for example, a Medicare patient presents with a hip fracture. We know what to do. There are protocols, right? We
Right.
put in a Foley catheter. We, do the X-ray examination. If they're elderly, we get the medical clearance. Generally, it's not referred to as medical clearance anymore. We get the medical risk stratification, and we get them to the OR as expeditiously as possible for the hip fracture, open reduction, internal fixation. That's just standard of care. But what Medicare is now requiring is that we get an inpatient authorization. So what that means is, yes, we do the hip replacement surgery, but within 48 hours, we need to get authorization from them for the quote unquote inpatient care, which is essentially a retroactive authorization, prior authorization. So instead of calling it prior, because obviously it can't be prior,
Right.
it's inpatient authorization.
Ah, so you were you went and got an MBA on top of all your degrees in your specialty in order to be able to, with your husband, run a small group practice
Yes.
of orthopedists. Um, and yet, did it in the end, it taught you how to run a business, but it didn't tell you how to deal with this kind of what I can only say from a patient standpoint is irrationality.
Yes. Yes. So it was a decision on two parts. I have an interest in entrepreneurial ventures, tech, improving the way that we do surgery. So that was one motivation to want to get the MBA. But as you say, another motivation was really to learn how to operate the practice better. A lot of what you learn in the Masters of Business Administration is how to interact with people, project management, projections, crisis management, negotiations. There's so many things that I learned in the MBA that would have benefited me from medical school from jump. But the MBA, as you say, just created in me, I guess, a confidence that my assessment of this moving goal line was accurate. So it helped me to place a terminology, a framework, a vocabulary on what we were experiencing and what we had been experiencing over the last 20 years. It certainly didn't provide the solutions because we're basically on the front lines. And as a practice that manages our billing and our collections, we're seeing everything real time.
Yeah.
So the instructors, the professors at my business school or the professors at other business schools, they wouldn't know what's happening because, again, they're not on the front lines. We would have to be informing them of that. But that education allowed me then to really have an insight and a perspective. And it also helped me to undergird our staff to give them the mechanisms to be able to deal with things. And it also gave us the confidence to say, you know what, this is a losing battle. We have to engage attorneys to advocate for us and to remind the insurers of what the law really is. So,
I did an interview last year with uh, a general practitioner, as they still call them in England,
yes,
um, who who I got to through a professor who's somebody that my brother worked with at the London School of Economics,
yes,
and he had taken essentially the equivalent of what you took, being a well-practiced GP with his own business, just for the same reasons that you're talking about. And in England, it's even more necessary because each GP practice, which can be a number of physicians put together, along with imaging equipment and all the rest of it,
yes.
contracts individually with the NHS, the hospital
Mm,
system, the health system, as an individual contractor. And so they really are on their own. It's their own business that they make a deal with and go somewhere else to operate that business, and then see those patients when they're out of the hospital. So as I understand it, a lot of the bigger groups are doing that for just much of the same reasons, but without the insurance element of it, just the
correct.
doing business element of it.
Correct. I think there are a lot of similarities between what you're describing with the GP that you spoke with and the way that we operate. We have to have affiliation with hospitals in order to take care of patients who might need to be inpatient. We do some surgeries at what are called ambulatory surgery centers, which allow patients to come in and go home the same day. So we are navigating that gap between the business that we're running, the practice that we're operating, and these other facilities and their regulations, their operation styles. And then, as you say, with this third party insurance, as a small practice, what we found is that there's been decreasing access for us with the insurance companies. When I first came to the practice, there were physician liaisons that we had email addresses for, telephone numbers for. We could call them,
Mm.
talk to them about some of the issues that were ongoing with our patients. Those positions are fewer and farther between. And we're finding that it's extremely challenging to find a live person. And at the end of the day, again, as bearers of the bad news, we are asking our patients, because these insurance companies tend to be more responsive to the patient, asking the patients to call the insurance company and to put forth, the questions that we have and that we certainly would have broached on their behalf. But they have to call directly because we just don't have the access points. We don't have the liaisons anymore.
I had a little bit of that many years ago. I've a long orthopedic history with one of my knees. I was a marathoner, 30 marathons, and now my husband,
Congratulations.
about 70, is in my corner also with the knee replacement. But in the beginning, I just wanted more PT. And I belong to a union that is about movement, acting,
Yes.
singing, dancing, going out in the field and covering stories that could be anywhere where you
Yes.
climb up or climb down.
Right.
And the union would give you, I don't know, 12 weeks twice a year, something like that, or the insurance. And I needed more of it. And they turned me down, the insurance company, my union insurance company that runs its own. And I wrote, I still have the letter, the outrage, because what did I know?
Yes.
That that this is that kind of a union and you don't allow your members to be whole when they need this extra thing. And when I finally got the denial back, this was appeal after appeal, it was from a nurse, not a nurse practitioner. They didn't have those then, just a nurse who was the one doing the decision.
Yes.
Orthopedic nurse, maybe, but just a nurse. I was just so outraged. There was nowhere to go with it except, to the union, but it never got anywhere because
Yes.
in the end, the union has to pay for it, and they didn't want to pay for it either. It was very well known that no insurance company liked physical therapy. They thought it was a deep pit, that people just used. Um, and indeed, maybe for some people it might have been, but it certainly wasn't for those of us who moved, and who needed to.
Exactly. And
But
part of it's about education, part of it's about the resources that therapists have to work on a specific area. And
right.
what you're describing, I have really begun to align with the analogy of a David and Goliath. Every scenario, we feel like David, right? We're one against the Goliath of the corporation, the Goliath of the union. And we're having to, as you alluded to, maybe act out of character to get someone's attention,
Yeah.
to bring attention to what's happening with us. And we're just looking for that one smooth stone, right? To overturn a denial, to overturn that appeal. It's something that we're seeing more and more of, as you mentioned, from the time when you had this issue to current. It's a everyday occurrence, and it's something that really, like I said, it's like a micro trauma. It makes patients also hesitant to pursue another issue if they've been denied previously.
Right. So, all that we've been talking about and a lot more, because I listened to your podcast for UpMed, the Journal of Healthcare's Race to the Bottom. I love that name.
Thank you, Stephanie.
But I listened to a number of your podcasts, which went through these various areas. And so you've decided to write a book and pull it all together. Who is the book directed at?
That's a phenomenal question. And as a writer, you can relate to this. I had a tough time deciding, is this for patients or is this for their providers? And at the end of the day, I may regret this decision, but it's for everyone. It's for people who take care of patients and interact with the insurers. But I would say the majority of the material is really for patients or those who are interacting with insurance companies. And I think most of us are, because we have either aging parents or we have responsibilities for our children or responsibilities for ourselves. And I am targeting the insured audience that is dealing with the insurances. And essentially, I'm hoping to shed light on some of the things that you seem to be very familiar with in your role, but that many people may have a glimpse of, but don't really have the full picture. So my goal is really to shed like a texture and a light on this current state of things, and also to provide some suggestions for how to deal with it and move forward.
I do think there's still an attitude. I mean, I still have that. My husband and I, we talk about this a lot. We still kind of think, well, we have good insurance. It should be enough, you know. It would be
Yeah,
if I didn't have insurance, I should be worried, but I've got good insurance. It's never enough. And all the focus is on how the cost of health care for those who are on Obamacare and Medicaid will rise if the plans go through from the White House and Congress. But we're just normal people, and our insurance premiums have gone up enormously this year. So maybe you wouldn't think twice about a premium going up if nothing else were going up. But with everything, it's just one more thing. And I tend to think that there are an awful lot of us walking around with some form of, I wouldn't want to call it mental illness, but certainly some form of not being right,
yeah,
because we're not, we don't have MBAs, we don't have medical degrees, we don't know how to run a business, many of us. We just expect that if we pay money for something, we will get something back from it. And that's essentially the contract that I think you're saying is broken now.
correct. Very much so. I think you articulated that so well. Many of us believe in, I'll call it a social contract. We believe because the United States of America generally operates very well. If you travel abroad to different countries, the rules are a little different elsewhere. But here, we are a country that is run by the rule of law. We do have consumer protection agencies, consumer protection ideals, and companies are generally held to the standard of abiding by that. And if we collect money for a service here in the United States, we expect that that service will be provided. And you're exactly right to say that if we're paying thousands of dollars a month for our premiums, we would expect that when the time comes for us to receive health care, we would be able to receive that health care. But unfortunately, that's not the case. And more physicians, nurse practitioners, health systems, they're finding themselves in the scenario where they provided care and they're not even getting reimbursed for the care that they provided. Patients are finding themselves in the position where they've paid for premiums, they paid for insurance, quote unquote, but they can't take advantage of it in so many different ways, be it medication that a doctor has prescribed. There was one woman who wrote into one of the news stations in Pittsburgh, and I was asked to comment. She was denied multiple times for a medication that was prescribed by her doctor, a very unusual medication for thyroid disease, but she tried everything else, and this was the medication that was going to work for her, and her health system denied that just after multiple appeals. And so she's doomed basically to cope with her thyroid condition rather than take a medication that exists that is available, as you mentioned, a technology that does exist that could treat her problem. So we're looking at the scenario where patients are paying for healthcare, but they're not getting it.
Yeah. Well, um, I I hope your your book sheds, light on this and that people, I mean, we all are responsible for ourselves these days. There really isn't any helping hand out there where it used to be, it seems to. So we do have to know some of this stuff. Uh, um, I want to just before we wrap this up, move on a little bit to my favorite topic, which is technology.
Yes.
And I quit my eye doctor and the group that she was associated with a few years ago because I would walk in for my annual appointment, and I'd go to the reception desk, and there was a wall of folders behind the reception desk. And I'm like, what are those doing there? Well, we're not digitized. And I would go into the office, and there would be my folder, papers, and my doctor writing little notes that they stuck in and I'm like, what century are we in? This is absurd. So, I have been pushing for medical technology from the patient standpoint for years and years. And now we're beginning to get it. AI is beginning to do some good, but we still have all these separate patient portals that we deal with. So if I go to you as an orthopedist, and I go to my primary care doctor, and I go to the eye doctor, and I don't know, I go to my podiatrist, and each one of them, I have to put everything in again, fill every form out, all the, what are you allergic to, all the stuff, because they don't talk to each other.
Right.
So you say you're interested in technology. Where is this going to go and why is it so far behind?
That's a great, great question. And this has been an evolution that is at least, what, 20, probably 25 years in the making, correct? There was a big push right around the time I started practice for the electronic health record. And
Yeah.
there are a couple of companies that, of course, in US fashion, we just said it's open season. Let every company be formed and try to create their own electronic health record, their practice management systems. But there are a few that have risen to the top. I'm sure you're familiar with, most of us are familiar with Epic and MyChart.
Yes.
And so many health systems are in my chart. And I guess that at least gives you the ability to have one username, password, but still amongst institutions, I think if I'm going to one hospital, I have sign into my chart. And then if I'm going to a different hospital, I'm signing into a different my chart.
Right.
So we're still in that phase. Regarding what you addressed, though, in terms of having a practice that's digitized, I will say that I hear the opposite complaint more often than not. That the doctor is too much into the chart, too much into the computer, the electronic health record, and not enough into the patient that's sitting in the room with them.
Oh, I agree with
That,
you. I didn't even go into that. I never
yes,
get to look
yes.
my doctor in the eye, she's writing something.
Exactly. So I think the patient with the note scribbled in the doctor with the note scribbled in the file folder probably had more opportunity to look you in the eye and to look at you because she was doing things the way that they were done when she trained
Yeah,
in medicine. And I was trained at a time where it was somewhere in between where we were doing a lot of dictations and
right.
everything was sort of put into either a digital format or a paper format from, a dictation. But I do see that AI is improving that with AI dictation. It's something like a Siri where a physician can have an interaction with the patient and the AI will then create the note and the chart
Exactly.
relatively
Exactly.
accurately. So that is something that has become really popular in the last just year and a half, maybe 2 years tops.
That's good.
And we're seeing that it is improving, getting the physician's eyes away from the screen and onto the patient. And I think we do have a ways to go, though, from a surgical standpoint. Now, that's something that patients really wouldn't have insight into,
Mm.
but that's where my interest lies in creating efficiencies for utilization so that our surgery can be more environmentally friendly, where we're minimizing errors and the wastage of materials. And we're also looking at what materials, what instruments are of best benefit for the facility, for the environment, and giving our practices a grade essentially so that we can try to have more transparency on that. But another area where technology has really worked against the patient and the doctor is on the insurance side. They have these repricing companies that they utilize that are basically technology companies that kick back claims or deny claims, payment of claims based on uh, criteria that's not really transparent. And those companies get paid based on how they're able to reduce the reimbursements for claims, meaning that if they can save the insurance company, say $50, and it's usually more like $500,
Yeah.
then they will get a percentage of that money. So if they save the insurance company $500, the insurance company will pay them 150, 200, and on and on. So we're seeing technology used against, again, that patient-doctor relationship more than we're actually seeing the technology improving the electronic health record and the medical record.
Well, that's sad to hear. I spend a great deal of time in the Czech Republic. We we worked there for a long time, and we ended up buying an apartment. And I have many friends, and I've interviewed some of them for this podcast. And I'm like, what does it feel like to know that you don't have to think about any of these things? Well, they do
That's
have to think
great.
about it because each one of I've done a number of podcasts on different countries' government-run healthcare systems, and
Yes.
they vary. In the Czech Republic, they do have kind of state insurance companies. They differ to some extent, and they do have the ability to deny somebody something really expensive outside the norm for that country. But in general, there isn't. I have a friend who got really, really sick. She had heart issues. She had never really dealt with her health insurance or her health system and never thought much about it. But she came out saying it was there for me. I didn't have to do anything. I got sick. I called the doctor. They took over. They got me better, and I didn't pay a penny.
Mm,
And you look at that kind of assurance, and she always
yes.
knew if something happened to her, she wouldn't have to think about that.
Yes.
Yeah, they pay very high taxes, but in the end, they actually get something for it. I
Yes.
was so envious because I just think about us and how we worry about all of this.
Yes, and I agree because that's one of the talking points of the insurers when we look at what's next, where do we go from here? Quite often, the publicists and the public relations experts for the insurance companies, they will point to, say, Canada or the United Kingdom and convince us that as Americans, we don't want that kind of system. We want to have choice. We want to have independence and we want to have competition. And that's not the only, those aren't the only types of healthcare out there. You have the system in Germany, which works very well with multiple providers and multiple payers, but they do a better job with using technology
Mm.
to actually regulate and to audit the levels of care. And they're constantly um, seeking to improve the care that is provided based on what's happening. And for example, in COVID, they were able to continue to evaluate which vaccines were more efficacious. What are the results? Using data to make decisions. Who in the insurance company realm is using data to make decisions about care? They're using financial data,
Yeah.
but
Yeah.
not outcome data, not
Yeah.
medical data to make decisions. So there are alternatives.
And that outcome data is really important because that's what we don't have in this country. We
Yeah.
spend more money than other countries do, and we have not such good health care or outcomes. And that's what we need, I think, to concentrate on. Just a final question then, looking at outcomes in that sense. Leaving aside politics and everything else, do you think that with the help of technology now that we're just beginning, I mean, I would call it, tiptoeing into the water, really. And with some of the complaints now about insurance companies, I mean, they're very vocal, a lot of the complaints, and the breakthroughs, the wonderful breakthroughs that we're getting from a medical standpoint. Do you see our situation as ordinary people who are not terribly healthy getting any better in any kind of the near future that anybody can imagine?
No. And I know my publicist is going to slap me on the hand for that. And you're never just supposed to say no. But I believe that you cannot extract health and healthcare from society at large. And we talked about it briefly. Everything is more expensive. And understanding that in those communities that are under-resourced, be they rural communities or more inner city communities, but in those communities that are under-resourced, you will find that people are not able to get food. It was just on the news this morning, as we say, we're in October
Mm,
of 2025, and with the government shutdown, there's fear that federal employees who are looking at not receiving their next paycheck will be taking advantage of food banks and other resources. Well, you also have, again, in these rural communities and inner city communities, you have, again, those social determinants of health, the lack of available food, primary food like fresh fruits and vegetables,
that's true.
things that many of us take for granted.
Mm.
All of those things impact health. The stress of not knowing where your next meal is going to come from or not having financial stability, that affects your health, your blood pressure. Stress affects every organ system in our body, correct? So when we're looking at all of these societal pressures, it's really hard to predict that at large society is going to get better. And with the jobs numbers being at a low, with of course, the stock market continues to do well, but I think that's an
Amazingly.
artificial predictor of the health
Yeah.
of the society. But as the health of the society depreciates and we're finding more individuals in vulnerable circumstances, let's just say that. And I don't think that's a political comment. That's just a statement of reality. When we see that, then we can't expect that Americans are going to be healthier, that they're going to be doing well. There will be a percentage that will be able to take advantage of the technology, the healthcare opportunities that are available. And that's essentially how we're headed, right? We're headed to more of a bipolar society where
Yeah.
we have those who have and those who do not have, and a decreasing middle class, be it upper, middle, or lower middle. That middle is shrinking.
Well, on that happy note, and I don't have the knowledge you have. I don't have the statistical knowledge you have, but my gut agrees with you, just from what I see. As I said on that unhappy note, what is the name of your book? And I wish you great luck with it.
Oh, thank you so much. So the name is a little tricky. It's called The Invisible Hand Wielding the Scalpel. And it's really looking at the Adam Smith uh, Wealth of Nations characterization of the capitalist forces or the invisible hand. And Adam Smith, 18th century philosopher and economist, described the capitalist system in such a way that as the invisible hand, it's moving society, moving economic society toward improvement and toward growth. But what I'm describing is this invisible hand as the corporate insurers that are moving our health toward deterioration because of the limitations in access.
All right. Good luck with it. And thank you so much for coming on the podcast. I really enjoyed this, Erica.
Thank you, Stephanie. It's been a pleasure.
Dr. Erica Rowe Urquhart is a leading orthopedic surgeon who runs a private practice in New Jersey with her husband, who's also a highly credentialed orthopedist. Dr. Urquhart has a PhD in molecular and cellular neuroscience and served her orthopedic surgery residence at New York's renowned Hospital for Special Services. She also earned an MBA from Oxford's Said Business School. And she has a book coming out, likely during November, The Invisible Hand Wielding the Scalpel. I'll keep the show notes updated. With so much uncertainty in our own country about healthcare issues and the ability to even find the medical care or drugs or even the vaccines you need, we may be looking at either Canada's or Germany's government-run healthcare systems in our next episode. Are the waiting times as long as in the UK? Is basic care easier to find than here? For all? So, check the show notes on my website, which I'll update as soon as possible, and episode 39 will drop on the third Tuesday of November, since I schedule one new podcast episode a month. And as always, please subscribe and share the video versions on YouTube, audio on Apple, and on all the other major platforms, including my host platform, the Podbeam website and app. Show notes and links on my website, stephanieshelton.com/conversations. I'm Stephanie Shelton. Take care of yourself and all you love, and I'll see you around. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.